So anyway, as I said, thank you so much for coming today. We think that today is really a monumental event in that this testing that we're going to offer for you today, that actually you've already had your first one, is not taking on widespread use currently, but that has to change because, as you know, heart attack and stroke is the #1 killer, and we're not going to take it off the #1 spot if we don't look for early stage disease. So we can protect you from having a heart attack or stroke if we look at your arteries. So this is just a picture of the arterial system. The arteries are the blood vessels that give the blood supply to the whole body, to the brain, the nourished, oxygenated blood to the brain, to the heart, to the kidneys, to the whole body. And if you can keep your arteries healthy, then not only will you prevent heart attack and stroke, but vascular-related dementia, erectile dysfunction, peripheral vascular disease, kidney failure, etc. So we're in the habit in the medical community for many, many years looking for blockage, late stage disease. Okay, it's 80% blocked, now let's do something. Or you're having a heart attack and we've got a 99% blockage. We're really good in this country at opening that up very quickly, which is fantastic. You know, we've saved a lot of lives that way. But if we would look and screen for early stage disease, while it's well before it's blocking the flow of blood, that's when we can reverse and stabilize the process so that you can live out your life uninterrupted by heart attack and stroke. So today the test that we're going to do on you looks at the carotid arteries, those in your neck specifically. And when we look at the carotid artery, this is obviously a cross section of the artery, and the blood flows in the lumen, or the pipe if you will, this gray area. But with our ultrasound technology, we're going to be able to look at this wall at the what's called the intima and the intima media interface, which is just the anatomical name for the location where cholesterol and debris and stuff that you don't want in the walls of your arteries, that's where it resides. So we're going to be detectives with the ultrasound, looking very carefully as far down as we can see and as far up as we can see here in the carotid artery, scanning for any early stage disease in this intima media region. And when we meet again in a couple of weeks, then you'll know your results and know what that means for you and what you can do about it. So the image looks something like this. So this is what an ultrasound technology, the type of image it gives you. And in the past, as I said, we've been focused on the lumen or luminology. What about the arterial blood flow? We'll look for that too, because certainly we want to know if there's a blockage of blood flow. But before plaque clogs the artery, if we were focusing just on flow, we might miss a thickened area in the wall, such as this. So we're going to focus our attention to be like surveillance, if you will, on the wall of the artery. Very picky to know if it's the appropriate thickness for your age and gender, or if there's something that looks like atherosclerotic plaque. Atherosclerosis, as you know, is plaque in the wall of the artery. So that's what we're looking for today. Dr. Eldridge is one of the most experienced in this field, and so I want him to comment a little further. You have some excellent explanation of this.
Well, so the first thing I would comment is, why does it matter? Atherosclerosis, the disease we're talking about, is responsible for over 70% of the heart attacks and strokes, and that's too many. Statistically, 1 out of 4 of us will die from this disease, and it's 100% preventable. So you think about if that was car accidents or cancer or something, that we could be, if it was a gun, people would go nuts over it, that we were losing 1 out of 4 people. So the disease is not at all unlike acne. In fact, if you've ever had a sliver on the back of your hand, you know, if you leave the sliver, what will happen? It gets red and infected and gets pus-like if you leave it long enough. That's the way our body gets rid of the sliver. It pushes it out. Unfortunately, in our arteries, it doesn't push it out. It's a lot like a pimple on the artery. So if you think about when you were a teenager, you could feel an acne lesion forming long before you could see it in the mirror, right? The reason is because it would get inflamed. And that's what caused pain. But in our arteries, we can't feel that. But it's the same problem. In fact, the reason that most heart attacks and strokes are sudden and spontaneous, nobody calls in sick and says, "Oh, I think I'm coming down with a stroke," right? They just kill over in the parking lot. The reason for that, in most cases, is that these lesions rupture. And when they rupture, that white pussy material you'd find in a pimple gets pushed up almost instantaneously to the smaller vessels of your brain, and your brain can't breathe. It starves for blood and oxygen. You have a stroke, or to your heart, and you have a heart attack. But we can see with that ultrasound, we can see not only if you have the lesions, but we can see the inflammation that always precedes a lesion. It's physiologically impossible to grow a plaque without inflammation. So that's why it matters. And if we can catch it when it's still just inflammation before it's plaque, then Gina and other doctors like her can treat them and get rid of the inflammation, so you never grow a plaque. If you don't have plaque, you cannot have a heart attack or stroke from atherosclerosis anyway. So that gives a little bit of context. And
where does the plaque come from?
It's called a process called phagocytosis, but it's just like a sliver. In this case, instead of a sliver, a piece of wood in the back of your hand, it's a sliver of cholesterol that gets inside the skin of your artery, and it goes through this process called phagocytosis, which is just the process of your body trying to say, hey, you shouldn't be here, and it's trying to get rid of it.
Right.
And that leads to plaque. Ruptured plaque is what's responsible for most heart attacks and strokes. Like I said, there's a few electromagnetic anomalies and congenital defects, but those are a small percent. Aneurysms, everybody's heard of an aneurysm. That's a small percentage of the total number of events.
We had a question earlier. A gentleman asked, what about when somebody puts a stent in the coronary artery at the site of a plaque? Are y'all familiar with stents, coronary stenting, have a blockage? And I thought you had a great response to that, an analogy.
You all know somebody who's had a stent before? Yeah, so how would you feel if you went to your dentist and they only scraped one tooth? You wouldn't keep them as your dentist very long, would you? Because everybody knows intuitively, God, if I have plaque here, I probably have it in the back of my mouth. It's a systemic disease. So you don't ever get a plaque on one tooth, do we? Hygienists, I'm looking to say, do we ever? I don't think it ever happens. And so when we stent the artery, we're stenting 1 little centimeter. There's 68,000 miles of vessels, and what we do with the stent is we fix this much of it. So that should give us pause. That's why there's a lot of people still dying from heart attack or stroke. The cardiologists do a marvelous job, but they're only fixing that much of 68,000 miles worth of vessels.
Exactly.
So we should be advised that the preventing it, treating it systemically is a much more cogent approach than trying to fix, the size of a stent, which
For
is
sure.
about a couple of centimeters long.
Right. So that's when you need a prevention specialist for
Yeah.
sure. That's going to, like you say, cardiologists are highly trained in blockage of blood flow, but they don't really don't focus their time on. Well, they're so busy doing that. Let's face it, it's going to take all of us.
Well, they're ethically have their hands tied.
Yeah, that's true too.
You can appreciate that as a cardiologist. I can't justify ethically cracking your chest open for the fun of it. That would be wrong. We know that intuitively, and so the criteria that their hands are literally tied ethically. The criteria is you have to be 70% or more blocked, or you have to have had signs or symptoms. Neither of which is a good thing. Right? We don't want to wait till we're symptomatic or till we fail Dana's ultrasound test at 70% or more.
Exactly.
And the reason that they're ethically tied is because they're surgeons. They're going to go in and say, "Can I operate?"
Yeah.
And the answer is no. You can't just go and operate for the fun of it. You operate on people that are sick.
Absolutely
So-
right. So I applaud you for coming in before you have a problem.
Can I ask a question?
Please do.
I had mentioned this to my primary care physician,
Mhm.
and she said, well, you can have a cardiac calcium test and then you won't need this.
Oh,
I don't know what a cardiac calcium test is, so
Right.
I don't know how to evaluate what she was telling me.
It's a great question. Both that test and this test are great at screening for early stage disease. There are some nuances between the two. So coronary artery calcium score is done by computed tomography or a CT scanner. So you would go to the outpatient radiology center, they would slide you into a CT scanner, just takes about 20 seconds, they tell you to hold your breath, and then you go on your merry way, and then they send to your primary care doctor or to you the results. And the results tell us if there's any calcium in a heart artery, coronary artery, anywhere. If your score is 0, then there's no calcium. And your score can be anywhere from 0 to infinity. I don't know, I've seen them in the thousands. I don't think I've ever seen a
Yeah, they go.
2,000. And so that tells us the degree of calcification. And we know the cut points in terms of what's your risk based on how much calcium you have. Because if calcium is present in an artery anywhere, then atherosclerosis is present. The problem, or the pros and cons, I guess, of the coronary artery calcium score versus this scan
It's radiation.
is radiation exposure. That's right. The second is that a CT scanner can't visualize any plaque that's not calcified. And soft plaque that's new before it has this opportunity to stabilize.
The whitehead pimple.
Yeah, exactly.
Yeah.
Right. And so it would totally miss that. So your score could be 0, and technically you could have disease, but it's just not calcified yet.
Right.
This will pick up both soft and calcified plaque. The other important feature about ultrasound is that we can use it for surveillance and monitoring. In other words, if your arteries look great today, we're going to celebrate with you when we meet in a couple of weeks, and we're going to say, let's look again in a year just to make sure they still look that great. If we find some abnormalities, we're going to say, we definitely want to look again in a year, because between now and then, you and I are going to get busy, and we're going to find out why it's there. We're going to reverse those root causes. We're going to decrease inflammation, and in a year, it should look better. And if it doesn't by a year, it definitely will by 2 years, or we're not doing our job. By 3 years, it should look much better. That's just going on the statistics. The research tells us that oftentimes at a year it'll look better, but for sure by 2 and 3 if you're treating all the underlying reasons. So it's better for monitoring, whereas the coronary calcium score not so much. So they're both great tests, and she wasn't wrong in recommending that test, but I would just say there's advantages of this one as well.
Thank you, I understand that.
Would you have
No,
anything to say to
that's
that?
I couldn't have said it better myself. It's,
Okay.
that's a
Any other questions? No? Okay. Well, thank you so much again for coming. I guess we're ready to get started on our
Yes, yep.
training.